Welcome to Eye Contact, a video news program on issues and controversies in ophthalmology sponsored by EUROTIMES. I'm Dr. Soosan Jacob. Small incision lenticule extraction, or SMILE, is rapidly gaining in popularity among refractive surgeons. Its many purported advantages include the lack of flap-related complications, less dry eye, and good predictability. As more procedures are reported, new indications are emerging, but so are reports of complications. Today, we're speaking with Professor Dan Reinstein, London Vision Clinic, about reasons to smile. Welcome, Dr. Reinstein.
Thank you, Susan.
So, Dr. Reinstein, what are the relative merits of SMILE versus femtosecond LASIK and PRK for low to moderate myopia?
Well, the first thing to say is that I don't see SMILE as a procedure that replaces anything. PRK and LASIK are superb procedures, mature procedures with excellent outcomes and excellent safety, and they've had 25 years of development in them. SMILE is, relatively new in that sense, even though there have been 700,000 procedures already performed. And I would say that SMILE offers us the ability to do certain things that we couldn't do before. For example, treat someone who actually has a bit of dry eye, somebody that you just wouldn't have treated by LASIK. We will treat by SMILE, because as we go into thicker caps, 135, 145 micron caps, we're really avoiding any or minimal disruption to the nerve plexus, and we are observing much less meibomian gland dysfunction, irritation, and the like after. So it's enabled us to do certain cases that we wouldn't have otherwise done. You ask about low and moderate myopia. Well, LASIK is a phenomenal procedure for low and moderate myopia. So I wouldn't put them as one or the other. I would just say that SMILE offers the dry eye advantage, and it also offers, as you say, the no flap advantage. But that's not necessarily an advantage if LASIK is performed expertly and flap management is performed well. I mean, LASIK is performed in the US military for years. I mean, it's not a problem to have a flap. It's not that the flap is a problem. It's just that I think that patients are able to return to contact sports sooner. For example, if someone is a boxer, amateur boxer, they're 26 years old. Okay, I might have done PRK in that patient to get him to return to boxing sooner. Well, obviously now I'll do SMILE. I think the reason why my practice, for example, has switched to do mostly SMILE now is because the procedure itself works as well as LASIK, and it offers these recovery advantages. It's appealing to the patients, obviously, to have a minimally invasive procedure, and it makes sense. I mean, all of surgery is going minimal. I mean, when I was a medical student, a gallbladder surgery was an 18-inch incision, and the patient had drains coming out, lying in a bed for 3 weeks. Now it's an outpatient procedure through a few keyholes. So I think it's a logical progression, and it's obviously here to stay, and it's just adding to our ability to treat patients.
Do you think the biomechanical advantage that SMILE has over LASIK is also one of its plus points?
Definitely. As you say, one of the big advantages of SMILE is the biomechanical. The biomechanics change less with SMILE. Not that there's anything wrong with the biomechanics of LASIK. We've been doing LASIK for 25 years, and we know what the limitations of LASIK are, and we respect them, and ectasia is not a problem, even with LASIK. The same cases that you can't do with LASIK, you can't do with SMILE in terms of exclusions. But what SMILE offers from a biomechanical standpoint, and as you know, I published a paper on this a couple of years ago in the Journal of Refractive Surgery, where we demonstrated that micron per micron, SMILE induces less spherical aberration. And it does so by using larger optical zones which are removing more tissue, but they still leave the cornea stronger than a LASIK procedure. Not that LASIK is weak, but I'm just saying. And because of that triangulation of optical zone size, spherical aberration induction, and biomechanical change, SMILE is going to enable us to do much higher myopia than we could ever do with LASIK. High myopia was limited in PRK by the wound healing reaction. We call it haze, it's scarring. LASIK is limited in high myopia because the flap doesn't really contribute to the long-term biomechanics of the cornea. Now that we can do the procedure without altering the anterior stroma, which is double the strength of the posterior stroma, we now have a mechanical advantage to be able to do higher prescriptions, higher myopic prescriptions, and still leave the corneas at the same limit that we have been leaving LASIK corneas, but at a higher level of myopia. In fact, we started a prospective IRB-approved trial now of high myopia in London. We're going to open this as a multi-center trial in Europe and Asia, actually, we're hoping to, because that's where most of the high myopia is, where, for example, the protocol allows us to leave 220 microns under the lenticule. And that sounds scary, because if that's what you were doing with LASIK, that would be like 1991. But leaving 220 microns of stroma under the lenticule, when you have made a 130 micron cap, which includes 80 microns of anterior stroma, because 50 is epithelium, that 80 microns is added to the 220. So technically you've left 300 microns of uncut stroma, which is a conservative LASIK mechanical treatment, right? That's the conservative people. They leave 300. Right. So not only are you leaving total numerically 300 microns, but the 80 that you're including are not 80 down halfway inside the cornea. They're 80 from the front, almost twice the tensile strength. So the 80 is technically like 160 of posterior stroma. Now add 160 to 220, and you've got 380. So it's like a LASIK leaving 380. So that's why the biomechanics comes into the treatment limits and is going to be able to help a lot of patients who would have been forced, if they wanted refractive surgery, to have a lens inside their eye, which for a long eye is not always the desirable option, even if it's a phakic IOL. But opening a long eye, breaking the blood ocular barrier, all the other things that are introduced by a foreign body that needs monitoring every year. So hopefully SMILE is going to offer us an expansion into the high myopic range. Obviously the question is, what about low myopia? Well, we published a study on low myopia up to, from -1 to -350, and we found that yes, the visual recovery is not the same as LASIK, where people are seeing crystal clear on day one, but they catch up very quickly within a few days, and the results are the same. So we had 96% of our patients 20/20 with one treatment, no enhancements. And when we looked at the FDA data, and we looked at the lasers approved for LASIK, and we looked at the -350 bins, we found that the results were actually the same in those trials. So, I think what we can say about SMILE is that it has reached a point where it is equivalent to LASIK and PRK, where those procedures do very well. But on top of that, it offers some dry eye advantages, nerve plexus respect, if you like, extension of the range of treatment, which obviously we're going to have to prove, but I'm convinced that that is the case. And of course, from a patient standpoint, psychologically, I think it makes sense, because everybody wants to have a less invasive procedure, and we are now able to offer that to patients, and I think that can only be good.
Right. I think thanks for that discussion. Could you also let us know a little bit about what are the complications that are probably emerging, newer complications that probably haven't been seen with LASIK? Could you
Right.
discuss about that as well?
So complications that are specific to SMILE, let's divide them into learning curve complications and post-learning curve complications, those that would occur to me or you having done thousands of SMILE procedures already. The learning curve is, well, every procedure has a learning curve. My first SMILE procedure way back 2010 took me 25 minutes to remove the lenticule. My SMILE procedures now take me 25 seconds. So it's not, I didn't become a better surgeon, I just developed the technique and the laser settings, and all of these things have come about so that now the learning curve is pretty much done. So anybody starting SMILE, and this is true of any surgery, don't try and reinvent the wheel. Stick to the standard operating procedures. Zeiss are very meticulous about trying to standardize the introduction of SMILE in new centers. There is a standard operating procedure. I just reviewed the RSTPs, which is a sort of 8-page document, 120 points of exactly what you do at what point, when, and how. And if you stick to that, the learning curve will be pretty smooth. In terms of complications we haven't seen before, these are related to what are minor fluctuations in energy of the laser. And we have to understand that this technology is really, really cutting-edge laser technology, in the sense that at the wavelength that we're operating, this infrared wavelength, to get a large numerical aperture, to be able to make a 1 micron spot and place it with refractive accuracy within the cornea in 3D, the optics are very complex. I hear it's something like 38 kilos of glass in the Visumax. That's, in terms of how much optics are in here. And my understanding from, my colleagues at Zeiss in the engineering is that the precision required of the lens manufacturer to make these optics is so high that only 2 manufacturers in the world can make these optics. One of them is Zeiss, and the other one is a company in California. So the laser is operating at some very, very tight tolerances. So I'm going to describe a complication which is rare that I've learned, and it's really not surgeon error. It's not really laser error, it's laser tissue interaction error, where the energy changes slightly. The bubble pattern becomes wave-like, and it creates micro irregularities during the lenticular cut. And you will see this on post-op day 1. If you put heavy fluorescein in, you'll see a pattern of concentric rings. And the patient will have, 20, 25, 20, 30 best corrected vision. It's a little bit disconcerting. There's 2 good news parts of this. The first is that, by and large, I've seen this maybe 1 every 300-400 eyes. When this occurs, it is self-limiting. In other words, the epithelium does actually, over time, remodel over these irregularities, and patients get their contrast back. Not just their best spectacle corrected vision, they get their contrast back. Surprisingly. And it doesn't have any impact on the refractive error. The second is that when these irregularities occur and they're more severe, it's usually because there is a stromal architecture disturbance that was not detected pre-op. And these can be completely invisible. You can have an absolutely crystal clear, normal looking cornea at the slit lamp. I'm a cornea trained specialist, so I know how to look at a cornea. And there is I'm thinking of a particular patient, there was no history of herpes, of any zoster simplex, no trauma to the cornea, no foreign bodies removed as a child, nothing. And yet there were areas, what we call black spots, areas where the bubbles there was no cutting, it was like a window. And there were very difficult dissection areas. I punched through, with lamellar dissection, the blunt instrument, and they led to irregularities. the great thing about these complications, I mean, we don't want any complications, but the good thing about these complications is that they are repairable. They're repairable simply with a transepithelial PTK. And the patient I was thinking about as I'm speaking had a transepithelial, his best corrected vision was 2012 for his minus 250. And his best corrected went up to 2020. So he lost 3 lines. But with the transepithelial PTK, he regained his 3 lines, just one treatment.
Right.
And so I think that we are going to see new complications that are specifically related to femtocutting that are different from excimer cutting, where you could have some fluid on the interface that one didn't notice that was irregular, and it caused irregular astigmatism. But by and large, what we're finding is that the complications that we generate with SMILE are ones that we can easily rectify.
Right. Dr. Reinstein, just in a couple of lines, because we're running out of time, if you can just sum up with what are some of the newer applications of SMILE that are possibly coming up with the SMILE lenticules, the SMILE procedures.
Yeah, well, I mean, what's coming very shortly down the pike, of course, is hyperopia and mixed cylinder. Just to complete the armamentarium of primary refractive surgery. But also, we're looking at asymmetric treatment, of course. High order aberrations, coma, specific aberrations that, if they occur at higher levels in a nascent eye, which of course is rare, we might be able to incorporate into treatment. And of course, an area which, of course, you're very involved in, and which is allograft. Using a SMILE pocket to insert stromal tissue that has been fashioned by a femtosecond laser, and that's very exciting.
Thank you. Thank you for joining us, Dr. Reinstein. For more information on this and related topics, please visit us at eurotimes.org.